Hello, everyone. Happy evening. A very good evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. All right. Hi. Good evening, Dee. And yes, thank you so much, everyone, for that quick note. So, today we are here to simplify this again, a confusing, complicated topic of renal tubular syndromes, right? Barters, Gittelmans, Liddles, Gordons, Cons, all of this is what we are going to try to simplify in the today's session. How many of you find this topic confusing? Yes, post test for Pharmac, the new timetable, the targets that we have started, post test would be there on the Telegram group every day at 10 p.m. Okay, the post test would be at 10 p.m. after this class. Okay, yes, too confusing. Hannah, a lot of us find it confusing. And this should be one of the topics which should be there in your list of last minute revision, like one day before the exam. This is one of the topics that you should be revising because this is very, very high yield and it's a frequently asked topic in the exam. All right, so let's try and simplify that in the today's session. And let me tell you about the next class. When will we be meeting next? We would be meeting next tomorrow, 11th February, for the part 2 of the top 15 mnemonics in pharmacology. It's a KBMD with MCQ live quiz. That is KBMD. That is Kaun Banega MD. So it's a live quiz, live poll, and we will be doing the pharmacology mnemonics like we did in the today's class. I hope you all enjoyed those mnemonics. I've touched on the mixed bag topics. Same lines we will have tomorrow at 5 p.m. All right. And this is the timetable that I was talking about. We have started the daily targets that you guys would be following, trying to complete the daily targets. We've started with Pharmac, right? Please try and complete the daily targets. I've given you on the Telegram group. You will have a pre-test every day at 9 a.m. and you will have a post-test at 10 p.m. It's a free live quiz. It's a live quiz only, a live test only. So be there at that time. Later on, it will not be accessible. All right. So this is the plan. I've shared it on the group as well. All right, and before I forget, this is the batch which is your last minute resort in these last 3 months, and all in one revision batch where you will have 4 hours per day revision. It's a 140 hours revision. All the 19 subjects will be covered, and it's a 90 days plan. By 10th May, it will be done. You'll have 8 grand tests. You'll have top quality subject wise tests for each subject, and the plan is the structure is very good for this course, I would say. There are the revision classes. You get a break time for self-study and you give a test and then you have the discussion of the test. I don't think you can get anything better than this for your last minute revision. So to help you in this, we have also launched the 3 month subscription, which was not there before. Okay. So a 3 month subscription will be approximately 11,250 inclusive of the discount which you get after applying the code. Like Dr. Nikita Live, or any other code that you have, you can apply. And the best part, if you take a subscription now, you will get 1 month extra. Suppose you are taking now in February. So February, March, April, plus 1 month will also be there extra extension if you take a 3 month subscription today or tomorrow. It's a limited time offer. So try and take the subscription before this offer goes away because it will cover everything till your May, right? The month of May, it would be covered. So make sure you take it well in time. All right. If you want to have a last minute revision, it will also give you access. This subscription is for everything on the platform. The previous mnemonics classes that I have taken, or any other subject that you want to watch, radiology, rapid revision, any subject which is weak, you can definitely get, everything on the platform once you take a subscription. All right. So let's start with the discussion of our topic, that is renal tubular syndromes. Okay. So this is, give me a minute. Not able to see the chat. All right. So here, look at this. You can get image-based question like this. First, what is the site of action of these diuretics? Then what are the syndromes? What syndrome corresponds to what? Okay. So I am starting with this for diuretics. What diuretic acts at the PCT? What diuretic acts as a PCT? PCT bicarbonate reabsorption. We saw in renal tubular acidosis yesterday. Bicarbonate, bi is dimox, that is your acetazolamide, that is your carbonic anhydrase inhibitor, right? The next one you have at the thick ascending limb of the loop of Henle, it is your loop diuretics. At the DCT, it is your thiazides, and then you have your पोटेशियम स्पेरिंग डायूरेटिक्स विच एक्ट ENaC वाले यहाँ पे एक्ट करते हैं. So you can remember that this is basically alphabetically first carbonic anhydrase inhibitors, then loop, and then thiazides. So it is CLT, right? You have CLT that you have. Now the LTE that I have mentioned here, you can remember this. हमारे मोबाइल फोन पे LTE लिख के आता है बहुत बार, right? So LTE is your mnemonic basically for your starting with the loop. So first you have loop, then you have thiazides, and then you have the site of action of ENaC. Okay, this is the site of action of ENaC. So loop, thiazides, ENaC. If I go from proximal to distal, and to add to this, first you have is your carbonic anhydrase inhibitors, or it is acetazolamide. The syndromes, yes, very good, Chandrasekhar. Long-term evolution is the full form of that of LTE. Now, the syndromes, this has been relation to diuretics. Now, the syndromes that you have, just remember alphabetically the three most important syndromes. That is your B, G, and L. Again, this is alphabetical. Okay, again, this is alphabetical. So, you have Barter's, you have Gittelmans, and you have Liddell's. Okay, Barter's, Gittelmans, and Liddell's. I am just telling you these three. बाद में मैं आ रही हूँ वो Fanconi's वगैरह पे. Okay, so Barter's, Gittelmans, and you have Liddell's, and it is LTE. So Barter's is like loop, Gittelman is like thiazides, and ENaC wala is your Liddell's. But there's a difference in the two. ENaC wale diuretics, they inhibit the ENaC. Liddell's is overactivation of ENaC. Okay, so remember it's not similar to your potassium sparing diuretics. It is opposite of the potassium sparing diuretics, right? And यहाँ पे जो PCT में syndrome आता है, that is Fanconi's. Again, we saw yesterday, Fanconi's, PCT, what type of renal tubular acidosis it is? Type 1, type 2. Let's see. We discussed yesterday what renal tubular acidosis is it. What renal tubular acidosis? Very good. It is your RTA type 2. 2 is bi, that is bicarbonate, right? Bicarbonate wala acetazolamide, Fanconi's, these will go together. Okay, these will go together. Now, going to the next one. So this is what is mentioned here. कि ये जो है आपका, this is sodium potassium 2 chloride transporter, loop diuretic, Barter's. Sodium chloride transporter in the DCT, thiazide, Gittelmans. ENaC, you have inhibition of ENaC is amiloride, activation of ENaC is Liddell's. Okay, remember it's the opposite. Remember this is your BGL and this is your LTE. The ENaC wala acts here. Okay, everyone clear with this? The first point that we have learned. Right, the first point is clear with everyone. So remember LTE and remember BGL. Okay, these are similar. Loop is Barter's, thiazides is Gittelmans. ENaC inhibitor diuretic, ENaC overactivation is Liddell's. ENaC overactivation is Liddell's, right? It's a gain of function mutation in Liddell's. Okay. Now going to the next one. These are the syndromes again that are shown here. कि ये आपका nephron है, thick ascending limb. सबसे पहले यहाँ पे आएगा loop, right? The loop diuretics. Remember acting on the loop of Henle, the thick ascending limb. Loop LTE, right? Those are the diuretics that you have. The syndromes are B, G, L. So you have Barter's, right? Inhibition is Barter's. You have Gittelmans. You have Liddell's. The only thing to remember कि Liddles is the overactivation. The rest of them are the inhibition of the corresponding co-transporters. Another point to be noted here, I'll come to Gordon's and pseudo-hypoaldosteronism type 1 as well. A quick review, remember that जहां पे गिटलमैन है वहां पे गॉर्डन्स है. Okay, so G and G are together. Gittelman is inhibitory of the sodium chloride. Gordon's GOR, it is the overactivity of the sodium chloride. Okay, it is the overactivity of the sodium chloride. So Gittelman's and Gordon's go together. So Gordon's will be opposite of Gittelman's. Gittelman's is inhibitory NaCl. This is overactive NaCl. Okay. Liddles का उल्टा होता है pseudo hypoaldosteronism. This is pseudo hypoaldosteronism type 1. Okay, this is type 1. Now let's go to this one. Okay, the table. First, quickly, let's discuss about Liddles, Barters and Gittelmans. ये Liddles वाले पे मैं आ रही हूँ बाद में. पहले ये वाला table देख लो. Barters, Gittelmans and Liddles proximal to distal. That is B, G, L. That is alphabetically when you say B comes first, then G and then comes L. So B is Barters, first is ascending loop, then is distal tubule और फिर बाद में और आता है distal tubule, वहां पे होगा Liddles. This is your LTE. That is your Barters is like loop diuretics, that is furosemide. Gittelman is like thiazide. Liddles is opposite of the ENaC wale diuretics. Okay, it's opposite of ENaC. So ENaC का gain of function mutation होगा. ENaC is the final thing where aldosterone acts. Basically, the manifestations will be like increased aldosterone. Okay, like increased aldosterone. Yesterday, did we discuss aldosterone in our acid-base disorders, renal tubular acidosis? We discussed. Tell me, what does aldosterone cause? Increased aldosterone, does it cause acidosis or does it cause alkalosis? What does it cause? Increased aldosterone, does it cause acidosis or does it cause alkalosis? Very good. Aldosterone causes alkalosis, right? It causes alkalosis. Alkalosis means hypokalemia or hyperkalemia. Alkalosis means hypokalemia or hyperkalemia. It is all K loss, right? Alkalosis basically is all K loss. That means all potassium is lost. That means it is hypokalemia, right? It is hypokalemia. And so what will be the manifestation in Liddles? Liddles is similar to aldosterone, increased aldosterone, but actually without increased aldosterone. So even that will cause alkalosis with hypokalemia. How would be the blood pressure in Liddles? How would be the blood pressure in Liddles? Because it is like increased aldosterone, mineralocorticoid, salt retention, water retention. It will have hypertension, right? Remember, very, very important point to differentiate Barters, Gittelmans from Liddles. Okay. So look at this one, Barters, Gittelmans and Liddles. Since Barters is like loop diuretics, Gittelman is like thiazide diuretics. What will both of them cause? They are like diuretics. So there will be hypokalemia or hyperkalemia. Even here you will have hypokalemia, right? Even in Liddles we said, because this is similar to increased aldosterone, it causes hypokalemia, right? So all the three will cause hypokalemia. Hypokalemia, all K loss means all the three will cause metabolic alkalosis. Okay, all the three will cause metabolic alkalosis. Is this clear with everyone? So basically all the three will present with metabolic alkalosis with hypokalemia. But since Liddles is like aldosterone, it will be increased blood pressure, hypertension. Barters and Gittelmans will not have hypertension. They will be normotensive. They are like diuretics. They will not have hypertension. Okay, they will not have hypertension. Liddles will have hypertension. Okay, Liddles will have hypertension. Okay. Now coming to the next differentiating point between Barter's, Gittelmann's and Liddell's. Let me show you the table. So यहाँ पे सबको समझ में आया कि सीरम पोटेशियम सब में लो होगा, right? Blood pressure will be high only in Liddell's. Okay, blood pressure will be high only in Liddell's. Okay. Now coming to your renin aldosterone as well. What will happen to renin and what will happen to aldosterone in Barter's, Gittelmann's and Liddell's? Think logically and tell me Barter's and Gittelmann's. Okay, what will they do to the renin angiotensin system? The RAS system, what will happen with Barter's and Gittelmann's? What will happen in Barter's and Gittelmann's? They will be activated. Low renin, high renin. See, understand the concept. This is very, very important concept. RAS system, renin angiotensin aldosterone system, is stimulated by what factors? When you have volume depletion, that is volume contraction, or when the renal blood flow is decreased, that means like renal artery stenosis, that stimulates the RAS system. Okay, so either because of the volume contraction or because of the renal artery stenosis, these stimulate your RAS system. Barter's and Gittelmann's, because they cause volume contraction, because they are similar to diuretics, they will cause overactivation of the RAS system because they are like diuretics, the volume loss. So RAS system activated. So what will you have? You will have increased renin, you will have increased aldosterone. Okay, you will have increased renin, increased aldosterone. High renin, high aldosterone is what you will have. What happens in Liddell's? Liddell's is like the body feels that there's a lot of aldosterone, right? There's a lot of aldosterone-like activity because the ENaC is activated. So that is why the body feels that aldosterone बहुत ज़्यादा है in the body. We don't need more aldosterone. So it inhibits the aldosterone, right? It inhibits your RAS system. That is why you will have low renin, low aldosterone. Okay, low renin, low aldosterone is what you will see in Liddell's. So remember, Liddell's L for low. It is low renin, low aldosterone is what we see in Liddell's. A very, very important point to remember. Okay, a very, very important point to remember. So look at this one. Liddell's, basically जो हमने बोला Liddell's, there will be hypertension because it is like aldosterone. Hypernatremia because like aldosterone. Aldosterone, remember, saves the sodium, right? S for S. It kicks out potassium. K for K, kicks out potassium. So it causes hypokalemia. Hypokalemia, all K loss, alkalosis. Because it's like increased aldosterone, negative feedback, low renin, low aldosterone is what we will see. Remember, Liddell's is hypokalemia with hypertension. Inheritance pattern as compared to Barter's and Gittelmann's. Remember, Liddell, L-I-D. Liddell's is dominant. Okay, Liddell's is dominant. It's autosomal dominant. Barter's and Gittelmann's are autosomal recessive. Look at this one again. Focusing on Gittelmann's, Barter's and Liddell's. Barter, right? BGL, LTE. You have loop diuretic, you have thiazide, and this is ENaC overactivation, gain of function of ENaC. Okay. This is thick ascending limb, this is DCT, and this is collecting tubule. Very, very important. Liddell's presents with hypertension. Very, very important. Liddell's is hypotension. All the three is hypokalemia, alkalosis, hypokalemia, alkalosis, hypokalemia, alkalosis, right? All the three will have that. Okay. Remember that Liddell's presents like mineralocorticoid, aldosterone excess, but it has low aldosterone. Very, very important. L for L, low renin, low aldosterone. Which one has severe hypomagnesemia? Remember, Gittelmann's. Okay, Gittelmann is the one. Gittelmann, LMA. It has low magnesium. Okay, LMA, low magnesium. Excessively low magnesium is seen with Gittelmann. So when you have hypomagnesemia is severe, think of Gittelmann's. Which one has hypocalciuria, hypercalciuria? Which one has hypocalciuria and hypercalciuria basically? Remember, loop loses, right? Loop loses calcium in the urine, right? So basically in the urine you have increased the calcium. So there is hypercalciuria seen with loop. And which one is like loop diuretics? It is Barter's. Okay, Barter's is like loop diuretic. Okay, Barter's is like loop. So Barter's may hypercalciuria. Gittelman's is like thiazide. It would be hypocalciuria. Okay, hypocalciuria. Very, very important. Fanconi we have seen it is PCT may problem. Everything in the PCT reabsorption will not occur. So glucose diaga, okay, there would be glycosuria, there would be amino acid urea. Remember, this is the one, Fanconi's is the one which has acidosis. Okay, Fanconi's has acidosis like your acetazolamide proximal RTA, that is type 2. You will have hypophosphatemia क्योंकि वो यूरिन में जा रहा है, osteopenia होगा, right? Clear with everyone? Fanconi's, Gittelman's, Barter's, Liddell's. This is recessive. This is recessive. Liddell's is D. Liddell's is dominant. Okay, Liddell's is dominant. It has dominant inheritance. Okay, it has dominant inheritance. Any confusion so far? Any confusion so far? Right? So remember Liddell's basically. Okay, so what do you need to remember? Let's quickly revise what tricks we have learned. Liddell's is basically your low renin, low aldosterone. Okay, low renin, low aldosterone. It is dominant inheritance. Okay, it is dominant inheritance. Barter's is like loop. Gittelman's is like thiazide. And Liddell's is opposite of ENaC, LTE, and this is alphabetical. Acetazole amide के जैसे you have Fanconi's. Remember Fanconi's, C for carbonic anhydrase inhibitor, that is PCT affected. It causes acidosis. The rest of them cause alkalosis. Okay, the rest of them cause alkalosis. All right. Now going to the next one. Let's go to the next one. So this is the summary of what we have seen. Syndromes, Barter's, Gittelman's and Liddell's. पहले मैं इस पे focus कर रही हूँ. Barter's is like furosemide, Gittelman's is like thiazide, Liddell's is opposite of amiloride, triamterene का opposite. Barter's sodium potassium 2 chloride co-transporter, loss of function. Gittelman's loss of function of sodium chloride. Liddell's is gain of function of ENaC. All the three will have hypokalemia. Hypokalemia, all K loss, all the three will have alkalosis. Here, the hypertension will not be there. Only Liddell's will have hypertension. So, the differentiating point, Liddell's versus Barter's, Gittelman's, hypertension, low renin, low aldosterone, and it is autosomal dominant. Okay, and it is autosomal dominant. Now, going to the next one. What is Gordon's and what is pseudo-hypoaldosteronism type 1? Gordon's is, remember Gordon's is though. That means it is pseudo-hypoaldosteronism type 2, though. And you have pseudo-hypoaldosteronism type 1, which is opposite of Liddell's. Okay, so now I am talking about the less common ones, but important for your exam. That is pseudo-hypoaldosteronism type 1 and type 2. Type 1, remember 1 when you write, okay, when you write 1, it is like L, right, when I write Liddell's. So 1 is opposite of Liddell's. Gordon's type 2 is opposite of Gittelman's. Okay, it is opposite of Gittelman's. In Gittelman's, loss of function of sodium chloride. Here you have gain of function of sodium chloride. Liddell's is gain of function of ENaC. Pseudo-hypoaldosteronism type 1 is loss of function of ENaC. Okay, it's a loss of function of ENaC. Right? So they will be opposite. So both of them will cause acidosis. Right? Because aldosterone causes alkalosis. Hypoaldosteronism will be acidosis. Acidosis means they have hyperkalemia. Okay, they have hyperkalemia. Okay, and the blood pressure is high here, the blood pressure is low here. Okay, because you have a lot of sodium getting absorbed, so the sodium increases. क्योंकि sodium absorption बढ़ रहा है, तो blood pressure बढ़ेगा. Okay, the blood pressure will be high. Here the blood pressure is low, the sodium is low. Okay, so let's revise this point. Pseudo hypoaldosteronism type 1. 1 is like L, that is Liddell's ka opposite. Liddell's ka opposite. Okay, it's a decreased loss of function of ENaC. It is ulta of Liddell's. Okay, the child will have hyperkalemia because it's opposite of Liddell's. There would be hypoaldosteronism features, sodium wasting, there would be acidosis. Okay, there would be acidosis. So basically, what is the thing that differentiates this from type 4 RTA? You remember the type 4 renal tubular acidosis we discussed yesterday? 4 is like A, that is aldosterone deficiency or excess. It is aldosterone deficiency which causes acidosis. This is also hypoaldosteronism jaise, but what is the difference here? Pseudo hypoaldosterone, that means like resistance. Okay, like you have in metabolic syndrome, insulin resistance. There is high insulin. Okay, here the aldosterone is actually high, but it's the loss of function of ENaC because of which you are not getting the aldosterone effects in the body. So that is why it is pseudo hypoaldosteronism. So aldosterone is high, but it's not showing its effect because the receptor is not responding. Right? So that is why type 4 RTA will not have, it will be hypoaldosteronism. Your pseudo hypoaldosteronism type 1 would be raised plasma aldosterone. Okay, that will have raised plasma aldosterone. Okay, look at this one. Type 2 pseudo hypoaldosteronism. It is with hypertension because you have increased NaCl reabsorption. It is Gordon's, opposite of Gittelmann's. NaCl is more active. That is why you will have ECF which expands. When the volume expands, renin decreases, aldosterone decreases. If aldosterone is decreasing, there will be acidosis, there will be hyperkalemia, right? So remember that Gordon's will have hypertension. It is pseudo hypoaldosteronism type 2. It will have hypertension. Okay. Next point, ये है आपका Gordon's का, the same thing that we read about Gordon's. It will have hypertension, very important. Okay, hyperkalemia, acidosis is what we will see. ये वाला है आपका final table. Okay. So yes, absolutely right, Pratibha. So basically, it is Liddell's and Gordon's which have hypertension. If I go back here, hypertension किसमें है? Gordon's and Liddell's. Gordon's and Liddell's is where you will see the increased blood pressure. Okay, Gordon's and Liddell's will have increased blood pressure. Okay, next one, let's go to the next. Adding to the syndrome, अगर ये कम नहीं है तो और एक ऐड कर देते हैं syndrome, which is the Cons syndrome. Let's add the Cons syndrome here. Because some of you mentioned you want to basically focus on cons as well. See, cons is basically primary aldosterone high. That means without renin. ठीक है, अभी आपको सिस्टम पता है, RAS system, renin, angiotensin, aldosterone. Aldosterone is the one which is controlled by renin. Aldosterone can increase on its own, right? Adrenal में activity बढ़ गई, खुद से बढ़ सकता है, that is primary. So in that case, you will have increased aldosterone, but the renin will be low. That is what we see in cons. It is low renin, but the aldosterone is high, right? Aldosterone, alkalosis, all-K loss, potassium will be low. Aldosterone saves sodium, it will be hypernatremia, right? What is the opposite? In Liddell's में क्या होता है? What happens in Liddell's? Liddell's is low aldosterone. That is very, very important. इसमें without aldosterone, we are getting the effects in the body like aldosterone. That is Liddell's. So remember that Liddell is like a riddle. It's a riddle. It's a riddle is which is a condition which presents like increased aldosterone but with normal aldosterone. That's the riddle there. That is your liddles. Okay, that is your liddles. So even liddles will have low renin, low aldosterone. Cons is low renin, high aldosterone. Okay, cons is low renin, high aldosterone. Where will you see that the renin is increased, the aldosterone is increased? Where it's the primary renin which is high, right? Like the renin secreting tumor, the renal artery stenosis. Basically, the secondary causes will have high renin, high aldosterone. Okay. Just to add here, remember that licorice, बहुत बार ये आपके MCQ में आता है. Licorice is like liddles that you can see here. It is low renin, low aldosterone, and you will have hypokalemia and you will have the sodium which is high. It is licorice is like liddles. It is your 11 beta DHT enzyme inhibitor. Okay, 11 beta DHT. So if I have to summarize this all, whatever we have learned, okay, whatever we have learned, that is your Barter's, right? Let me write down the most important. Barter's, Gittelmann's, Liddell's, then you have Cons, and let's say then you have renal artery stenosis, right? And then you have pseudo hypoaldosteronism type 1, pseudo hypoaldosteronism type 2. Okay, this is all that we have learned here. Now, Barter's. What is Barter's like? Barter's is basically like loop diuretics. Gittelmann's is similar to thiazide. Liddell's is opposite of ENaC. Cons, I'll come to this later. पहले ये तीन देख लो. ये क्योंकि diuretics के जैसा है, this will cause hypokalemia. This is opposite of ENaC. ENaC वाले are potassium sparing diuretics. This is opposite. So even this will cause hypokalemia. So all of them basically will have metabolic alkalosis, right? Liddell's is the only one which has hypertension which is present. There's no hypertension in Barter's and Gittelmann's because they are like diuretics. Now, since Barter's and Gittelmann's are like diuretics, they stimulate the RAS system क्योंकि volume contraction होगा. So you will see high renin, high aldosterone. Because Liddell's is like increased aldosterone, effects like increased aldosterone, but with low aldosterone. Negative feedback, low renin, low aldosterone, right? Remember, Barter's and Gittelmann's, autosomal recessive. Liddell's is autosomal dominant. Liddell's is low renin, low aldosterone, autosomal dominant. Which is the other syndrome where you have hypertension? Cons में भी होगा. Cons is primary increased in aldosterone, high aldosterone alkalosis, even that will cause hypokalemia, even that will have hypertension, but your aldosterone will be high. That is the difference between Liddell's and Cons. Low aldosterone, high aldosterone. So remember, Liddell's is low, Cons is high. Okay, Cons is high aldosterone. Renal artery stenosis, by decreasing the renal blood flow, it will stimulate the RAS system. RAS stimulates RAS. You will have high renin, you will have high aldosterone. Everything will be high. In Cons, aldosterone is high, but increased aldosterone inhibits the renin. So you will have low renin. That's the difference between RAS, renal artery stenosis, and Cons. Pseudo hypoaldosteronism, type 1 and type 2. Type 1 is like L, it is opposite of Liddell's. That means loss of function of ENaC. The ENaC is not responding to aldosterone. So aldosterone resistance, basically the aldosterone is high. And that is why you will see the features like pseudo hypoaldosteronism. These will present with acidosis. Okay, these will present with acidosis because they are hypoaldosteronism. Okay, acidosis, hyperkalemia. Type 2 is your Gordon's. Gordon's is opposite of Gittelmann's. That means where is the defect? NaCl co-transporter like thiazide. That gets activated. It is gain of function. So more sodium reabsorbed, that will lead to hypertension. So Gordon's and Liddell's have hypertension, this will have hypertension. Okay, this will have hypertension. It will have increased sodium because sodium is reabsorbed. Is that clear with everyone? So what we have learned about the syndromes, right? I hope this is clear. All the syndromes that we have discussed about, right? Any queries in the syndromes here? So remember, hypertension is Gordon's and it is Liddell's. Okay, Gordon's and Liddell's have hypertension. Gordon's is acidosis and Liddell's is alkalosis, because Liddell's is like aldosterone, Gordon's is like decreased aldosterone. Okay, and next Barter's, Gittelman's, Liddell's में देख लिया कि Liddell's में hypertension होगा, Liddell's में low renin, low aldosterone होगा, यहाँ पे उल्टा होगा. Liddell's is autosomal dominant, this is autosomal recessive, right? This is the difference between that. If I ask you what's the difference between Liddell's and Conn's, what is the difference between Liddell's versus Conn's? Conn's is primary hyperaldosteronism. There will be increased aldosterone. Liddell's is without increase in aldosterone. It will have low aldosterone. Okay, it will have low aldosterone that we would be seeing, right? So that's the difference between the two, though both of them present with increased aldosterone-like features. I'm sure that this is confusing topic, whatever we have discussed, the renal tubular acidosis, the renal tubular syndromes. So I will plan a quiz on this so that this is clear with everyone. I'll get some MCQs for discussion in the next class, right? We'll have MCQs. So remember this एक final वाला कि mineralocorticoid excess में जो आएगा, या mineralocorticoid excess that you have, that is including your Liddell's, that is gain of function of ENaC. Okay, you have Gittelman's, Barter's, but they are normotensive. Okay, they are normotensive. Okay, you have high aldosterone with primary aldosteronism, low renin. Okay, that would be low renin. Barter's and Gittelman's volume depletion, they lead to high renin, high aldosterone. That is secondary aldosteronism. Okay, low aldosterone is your Liddell's. Low renin, low aldosterone, that is your Liddell's. Okay, that's your Liddell's. And you also have licorice, which is similar to your, Liddell's. Licorice is like Liddell's. Okay, these are some of the points that I want you to remember. ठीक है, इसको एक note down कर लेना in a sticky note. Everything has been covered with concepts. More than mnemonics. Here it is the concepts that you should remember. Okay, the concepts that you should remember. When does the RAS get activated? When does the renin gets inhibited? Or when will you see acidosis? When will you see alkalosis? All of this. Okay. So yes, guys, that was about today's discussion of the renal tubular syndromes, including comparison with Conn's and mineralocorticoid excess. Okay, including the Conn's and the pseudo hypoaldosteronism as well. Okay. So thank you so much for joining in. I'll see you again tomorrow at 5 p.m. for the free live class on the Unacademy app, where we are going to discuss mnemonics in pharmacology, the top 10 mnemonics part 2. Like we had part 1 today. I'll enroll in. You can use the code Dr. Nikita Live for enrolling for the free live classes on the platform. All right. Thank you so much. Goodbye. Take care and keep studying. Keep revising and keep winning.